Thank you for joining my presentation on COPD-OSA, the overlap syndrome, evolving evidence. My name is Terrence Shenfield and I am the co-owner of A&T Respiratory Lectures. This is a very interesting topic because it talks about patients who have obstructive sleep apnea and they also have COPD. And sometimes that could be a double whammy for some patients. So at the end of this presentation, you're going to have a good understanding of how everything works. The objectives for today's presentations, I'm going to look at some of the statistics of the patients who suffer from the overlap syndrome. I'm going to describe exactly what is the overlap syndrome. I'm going to talk a little bit about the pathophysiology. I'm also going to be talking about the clinical consequences. And most importantly, I'm going to talk about treatment options. And then I'm going to reflect on some studies that have been recently come out on the overlap syndrome. By the end of this presentation, you'll have a good understanding of exactly what you need to know about this. No one needs an introduction. What exactly is chronic obstructive pulmonary disease, or COPD? It is the fourth leading cause of morbidity and mortality in the United States. Its prevalence in adults is approximately 13.9%. It actually impacts the quality of life of many patients. The most common signs is coughing, wheezing, shortness of breath, and hypoxia. The hypoxia portion of COPD is critical to understanding overlap syndrome. Now, when we talk about obstructive sleep apnea, this is a disease that impacts many adults across America and is basically caused by closure of the upper airway during the sleep. Obviously, the impact of obstructive sleep apnea impacts oxygenation too. So when you really think about it, if someone has COPD and someone has obstructive sleep apnea, their level of desaturation of those patients is much worse than either group by themselves. And the prevalence of obstructive sleep apnea is approximately 9 to 26% in adults, and it's probably underestimated. Untreated OSA can lead to heart disease, insulin resistance, diabetes, hypertension. There's so many diseases that are caused by the result of obstructive sleep apnea. They got this term where they call overlap syndrome. And this was first described in the 1980s. And what they're talking about is patients who have a combination of COPD as well as OSA. And you can imagine that a patient who has a combination of these two disorders is probably in worse shape than someone who had those individually. And they estimate that approximately 10 to 30% of patients with COPD actually may have what is known as the overlap syndrome. And the overlap syndrome, one of the key points to this is if someone has COPD, obviously they're going to be hypoxic because they're not going to be able to oxygenate as well as a normal person. Someone with OSA may have no problem with oxygenation, but their problem is obstruction. So they become hypoxic due to obstruction. But if you think about a patient who has a combination of COPD, which causes hypoxia, and then you're talking about someone with OSA who has obstruction, the impact on this patient can be much worse, and we're going to talk a little bit more about that. So I just wanted to give you an idea of what overlap syndrome is, and I'm going to explain a little bit more detail as we move on. So why is it so important for patients who suffer from COPD as well as obstructive sleep apnea having a problem with overlap syndrome? The problem is most of the time a COPD patient actually lives with lower levels of oxygen 24 hours a day. In other words, you might have someone with obstructive sleep apnea, but they might have normal oxygenation during the day, but when they go to sleep and they get obstructed, they desat and their oxygenation status gets worse. But for patients who have overlap syndrome, there's a real problem because it could result in cardiovascular disease. And what that means is during the night, when you have a COPD patient who normally lives at lower levels of oxygen, and all of a sudden they become obstructed at night, they have a real precarious drop in their oxygenation status, which can increase the likelihood of cardiovascular disorders. A lot of these patients who suffer from overlap syndrome, who are in REM sleep, become severely hypoxic. They've done some studies with patients where they did some pulse oximetry on them, and the patients who started going into REM sleep really became hypoxic, especially of this group. And the idea, if you become extremely hypoxic, there's a whole host of cardiovascular disorders that could impact you, and we'll get a little bit more of that into the next slide. So the relationship between overlap syndrome and heart failure is really quite real. And a lot of patients who suffer from just plain old sleep apnea end up having some kind of hypertension as a result, unless they're treated with nasal CPAP. But what happens in these patients, normally the brain senses the low levels of oxygen that occur as a result of the airway being collapsed. The natural response of the body when it doesn't have oxygen is to have a sympathetic response. And during this sympathetic response, catecholamines are released, and the most common hormones released are dopamine, norepinephrine, and epinephrine. The release of these chemicals when you're sleeping is not the best thing, because actually this has been shown to be a precursor to hypertension. So what happens is the body's release these chemicals, these hormones. You get, as a result of a sympathetic response, you get more pressures in the heart than is really necessary. And what happens is this leads into heart failure. We're going to talk a little bit more about this as we move on, but this is why it's such an important thing. These patients desat so precariously, and then as a result of desatting, they get this sympathetic response where 3 hormones are released. This sympathetic response actually increases pressures in the heart, which leads to hypertension. And this is really the crux of the problem with this particular disorder. So let's get into a little bit of the disease process of COPD. What exactly is chronic obstructive pulmonary disease? It is estimated there's approximately 250 million people in the world who have COPD. And those are the people who have been diagnosed. There are many people who have COPD that are not diagnosed. In the United States, it is estimated that there's approximately 16 million people who suffer from COPD. But again, many of those people are not, this is probably a low number compared to the total number. The number one risk factor for COPD is cigarette smoking. My mom, who was a COPD, smoked cigarettes her whole life, ended up getting COPD at 55, and that was one of the reasons why I went into respiratory care. I wanted to make sure I could do the best for her. And, I started respiratory therapy in 1992, and by 1995, she was diagnosed, and, there's a lot of reasons for it. Smoking, air pollutants, early childhood infections, genetics, if you're genetically predisposed, and occupational exposure. People who work in different type of environments can inhale gas and, be not good. So the typical symptoms of COPD, and it doesn't get better over time, is coughing. It could be with or without sputum production, wheezing, tightness of the chest, and sometimes weight loss. The quality of life of a patient with COPD is really poor. The prognosis is poor. The only thing you can do is manage the disorder rather than cure it. Over the years, much research has focused on COPD, and they have findings that many patients who suffer from COPD also have difficult sleep patterns. You know, when you wake up in the middle of the night coughing or wheezing or you're not breathing good, you know, this is a common fact that you're going to end up coughing and being awake. COPD can lead to small airway damage, and the result is the alveoli get destroyed, the alveolar capillary membranes get destroyed, and oxygen is not being delivered to the capillary membrane for cellular uptake, and this causes a whole host of problems. Chronic hypoxemia in COPD is quite common, resulting in patients needing supplemental oxygen to survive. Not all COPD patients need oxygen, but a significant amount of them do. And then there are COPDers who hypoventilate at night. They don't get good oxygenation at night, and those are ones who really suffer, and we're going to get a little bit more into that later. Patients with COPD typically will sat anywhere between 88 and 92%, and that's sort of normal for them. If you have a saturation of less than 88% or lower, you're going to probably require some form of oxygen therapy. And if your sats are 84% or lower, you really should go to the hospital. These are some like telltale signs of COPD, what to do and how to manage it. So let's turn our attention to obstructive sleep apnea. It is estimated that globally around the world, there's about 20% of the world have some form of obstructive sleep apnea. Here in the United States, there's approximately 30 million people who they suspect have sleep apnea, but only about 6 million have been diagnosed. Sleep apnea, obstructive sleep apnea, impacts so many people, and so many people are not diagnosed to know if they actually have it or not. Certain populations are at bigger risk than others, such as African Americans, Native Americans, and Hispanics. They've been shown a disproportionately higher rate of obstructive sleep apnea compared to other races. Sleep apnea impacts men more than women, and I'm talking about obstructive sleep apnea. A lot of times this has to do with the risk factors such as being obese, and it seems like men are a little bit more obese than women on the most part. Risk factors for sleep apnea include genetics, being older, certain medications such as antihistamine, benzodiazepines, barbiturates, and opiates. They could impact your sleep quality. Lying on your back is another risk factor, smoking, and most notably being obese. Obese patients actually have a whole host of problems with sleep apnea, in the sense that they have so much adipose tissue around their neck that their airways are narrowed by the fat. When we sleep, the upper airway muscles collapse over the airway. This is the common definition of obstructive sleep apnea. And even though the diaphragm is trying to trigger to breathe, you know, your body is telling you breathe, breathe, breathe. But what's the problem is that your upper airway collapses, your tongues roll back, occludes the airway, and then you don't get any kind of breath in. And this is what causes that catecholamine response, where you get that sympathetic response and you get the release of these hormones. And the common treatment for obstructive sleep apnea, which works pretty well, is CPAP. CPAP has done wonders for this. So now that we have an understanding of what COPD is and what obstructive sleep apnea is, now we're going to focus our attention to the overlap syndrome. So let's talk about the sleep quality of COPD patients. Many patients with COPD commonly complain of poor sleep quality and fatigue during the day. A lot of times these patients are frequently woken up during their sleep, and 39% of them complain of some form of cough during the night, and that is the reason they can't maintain sleep, so they wake up coughing. If they cough and they have wheeze, 53% of them say they have a hard time initiating and maintaining sleep. So obviously, COPD impacts sleep quality. Clinicians need to differentiate between isolated nocturnal hypoxemia and COPD versus hypoxemia due to obstructive airway hypoventilation syndrome with OSA. So basically, it's kind of difficult to determine whether a COPD patient becomes hypoxic due to nocturnal hypoxemia or versus obstructive sleep apnea. And that is the job of the sleep technologist and the physician to determine what kind of combination of the two we have. Here are some definitions that you may want to know, and this is how to differentiate between an isolated nocturnal hypoxemia with COPD versus hypoxemia due to obstructive airway hypoventilation and obstructive sleep apnea. Kind of tricky, but isolated hypoxemia is defined as a partial pressure of oxygen, a PaO2, of less than 55 or an oxygen saturation less than 88% for at least 5 minutes during sleep. So that is how you define isolated hypoxemia. Sleep hypoventilation is defined as an increase in partial pressure of carbon dioxide or PaCO2 more than 55 for 10 minutes during sleep, or an increase of PaCO2 by 10 millimeters above the awake supine value over 50 millimeters for 10 minutes. So these are the classic definitions of how to differentiate between isolated nocturnal hypoxemia with COPD versus hypoxemia due to obstructive airway hypoventilation in OSA. Kind of tricky, but I figured I'd throw it out there for you anyway. So let's dig a little deeper. Sleep disordered breathing in COPD patients is mainly seen in the REM phase of sleep, and the reason they believe that is due to reduced intercostal muscle activity and chest wall mobility. That is the reason they believe this occurs. This hypotonic muscle activity during sleep results in severe drop in minute ventilation in COPD patients. If a patient has a reduced minute ventilation, they're not going to be able to remove CO2, which is kind of obvious. It is estimated that the fall in minute ventilation from wakefulness to non-REM sleep is approximately 16%, and then when the patient goes into REM sleep, it further drops down to 32%. So this is a major drop in ventilation and minute ventilation. This drop in minute ventilation actually results in more pronounced hypoxemia and hypoventilation, resulting in increased CO2 levels. So this is the mechanism. It seems like during REM sleep, this is when the patients mostly suffer due to a decrease in minute ventilation, which causes both hypoxemia as well as hypoventilation. Reduced chest wall mobility and relaxation of the intercostal muscles during REM sleep precipitates nocturnal hypoxia. When this occurs, it further reduces functional residual capacities in these patients, so they have their FRCs as low. What this ends up is these patients take these rapid, shallow breathing patterns during REM sleep, which further reduces alveolar ventilation. When you have rapid, shallow breathing, your gas doesn't take place. You don't have gas exchange, removing CO2 and then replenishing with oxygen. So this is a further problem with the combination of COPD and OSA. One of the most common findings that is of concern is nocturnal oxygen desaturation in the COPD patients. The graph on the bottom shows you how levels of desaturations occur at different stages of sleep, and most likely it's going to be done in REM sleep. Nocturnal oxygen desaturation is considered to be a major consequence of disturbed breathing and sleep matters with COPD patients. There are three mechanisms that contribute to NOD, and one of them is alveolar hyperventilation. The other one is decreased ventilation perfusion matching. And finally, the third one is decreased end expiratory volume, ERV. COPD patients suffer from all three categories. They have what is known as alveolar hyperventilation. Because the alveolar is damaged in these patients, they don't really do too well in regard to oxygenation. Obviously, this results in ventilation perfusion mismatching, and they also have end expiratory reserve volume, which is decreased. The thing with this is that overlap syndrome patients have an increased risk of NOD compared to straight COPD patients, and this results in respiratory failure and hypercapnia. So, COPD patients always suffer from this on a regular basis, but if you happen to have overlap syndrome, you suffer even more, and your mortality, morbidity goes up through the roof. Overlap syndrome has a lot of problems with pro-inflammatory mediators resulting from hypoxemia. Hypoxia results in the release of inflammatory mediators such as C-reactive protein, nuclear factor kappa beta, tumor necrosing factor, and a host of other pro-inflammatory mediators. These pro-inflammatory mediators cause inflammation in the body. Another problem is the free radicals that are produced from hypoxia. Intermittent hypoxia induces what is known as oxidative stress. Oxidative stress has been linked to inflammation. Both of these have been linked to endothelial dysfunction as well as atherosclerosis. So the bottom line is hypoxia causes all these releases of inflammatory mediators. It also releases these oxidative stress or free radicals in the body, which further exacerbates the problem. All of this is precursors to endothelial dysfunction, atherosclerosis, and heart disease. So this is the underlying mechanism of how it occurs, and so many different parts of heart disease as a result of this. This is common knowledge, well published. Other risk factors for overlap syndrome is cigarette smoking. Basically, we all know that cigarette smoking can be a causative factor for COPD, but also exacerbates obstructive sleep apnea, and in our particular case, overlap syndrome. Smoking promotes oxidative stress and the release of inflammatory mediators that we spoke about on the previous slide, and this can accelerate pathophysiologic processes that cause harm to the body. Obesity is another risk factor for OSA. We all know that. We all know about adipose tissue in the upper airway could narrow the airway, but also adipose tissue stimulates the release of inflammatory mediators such as tumor necrosing factor and interleukin-6, which again predisposes to inflammatory state and again increases the oxidative stress, which results in harm to the body. Another problem is truncal obesity. Truncal obesity in these patients is someone with a big belly that'll push up against the diaphragm. So what happens, it impacts compliance of the chest wall. So these patients, the COPD patients or the OSA patients who are trying to breathe at night, they can't really take a good breath. They have small FRCs because of the obesity in the trunk. So truncal obesity is another risk factor that can impact chest wall compliance and muscle respiratory strength, thereby resulting in ventilatory disturbances. And again, this will cause more problems with overlap syndrome. So obesity, cigarette smoking, they're harmful in themselves, but in combination, they're the worst thing you could ever do. So let's talk about the clinical consequences of overlap syndrome. And just to refresh ourselves, overlap syndrome is a combination of having COPD and obstructive sleep apnea. The problem is COPDers typically live at a lower oxygen level than OSA patients. So the combination being OSA and COPD can be kind of lethal. Here's why. When a patient who's an OSA patient who is not a COPDer and they desat during the evening because they have the obstruction, they don't desat to such a low level as such as the overlap syndrome patient does who has COPD. So Because of this fact, because the desaturations are more severe with patients who have COPD and OSA or overlap syndrome, they are at increased mortality due to cardiovascular events. I got a little bit into the details of why the cardiovascular events occur, but I'm going to refresh you again. Remember, hypoxic drive leads to oxidative stress. We were talking about the fact that you're in a sympathetic nervous state where you have catecholamines releases, and this causes all kinds of havoc in the body. It releases systemic inflammatory mediators such as tumor necrosis factor, interleukin-6, interleukin-8, and C-reactive protein. All of this leads to endothelial dysfunction and atherosclerotic plaque formation. Also, OSA in itself leads to metabolic dysfunction such as insulin resistance and abnormal lipid metabolism. So you got these combination of factors going on where the oxidative stress is causing all kinds of inflammatory mediators being released, causes heart disease. OSA causes metabolic dysfunction, again, causes heart disease. And OSA is actually associated with systemic hypertension, and you're in increased risk of coronary artery disease, congestive heart failure, arrhythmias, and stroke. So you could see the combination between COPD and OSA can be quite lethal if not treated. To further the conversation about the consequences of overlap syndrome, patients with overlap syndrome have an increased risk of pulmonary hypertension and right heart failure secondary to underlying nocturnal oxygen desaturations, daytime hypoxemia and hypercapnia, as compared to COPD patients and OSA patients alone. So in other words, the overlap patients are at higher risk than anyone who has COPD by themselves or OSA by themselves. Studies have shown that 86% of the patients with overlap syndrome had pulmonary hypertension compared to only 16% of the patients who have OSA alone. So you could see that the patients with overlap syndrome are at greater risk for heart disease. Increased risk of developing pulmonary heart disease also increased with the frequency of deaths observed in sleep with OS patients. So basically, patients with obstructive sleep apnea who have COPD are increased risk for pulmonary heart disease and increase of morbidity and mortality as compared to one who has just COPD or OSA alone. And the stats speak for themselves. So this is a nice summary slide where it sort of summarizes everything I was talking about in the last few slides. So you have a patient with OSA, you have a patient with COPD. Both of these patients are hypoxic, for different reasons. The COPD patient because of alveolar destruction, the OSA patient because they have an occluded airway. Risk factors involved which can, aggravate the situation is obesity, smoking, and I listed a whole slew of things before. So you get a COPD or you get an OSA patient, you get some risk factors. They're all hypoxic. When they're hypoxic, there's a few different physiologic responses. First of all, you have the release of pro-inflammatory mediators that get released to the body, oxidative stress. This all leads to endothelial dysfunction, also leads to atherosclerotic plaque formation, which leads to heart disease. And that is why the end result is either you get some cardiovascular disease or you get pulmonary hypertension. Both of these things involve the heart. The heart is the organ that is mostly affected by overlap syndrome, and these are the reasons why I went over slide and I sort of beat that to death with you, but I wanted you to understand exactly how the whole process works. They were doing some interesting studies on the role of obstructive sleep apnea in oxygen status. Obviously, people would always say they desat during the night, and they were doing some studies to see which would be a better treatment option. Would it be CPAP or would they give supplemental oxygen, say via nasal cannula? And what they did, they looked at sleep disturbances measured at nighttime using the AHI, the Respiratory Disturbance Index, the RDI, or SDB events. And they were actually comparing CPAP versus oxygen. And they found that CPAP was much better at reducing apnea hypopnea index levels than straight oxygen. The problem with CPAP is they found poor compliance. There's a very poor compliance of people who should use CPAP who can benefit from it. Now they found that patients who used oxygen for NOD, nocturnal oxygen desaturations, they actually had more elevated levels of oxygen and their SATs were better at night using oxygen therapy. But overall, CPAP was better than oxygen therapy because it lowered the AHI, which actually had a better statistics regarding blood pressure and other parameters. So the point is this, people are going to desat during the night, and can you give them oxygen therapy by themselves? Yeah. Will they sat better? Yeah. Will the AHI go down? No. And so, but the problem with CPAP is the compliance level. And I got some more studies to show you on benefits of overlap syndrome and what kind of treatment options are available. But I just thought I'd throw this out there in regard to OSA and oxygenation status, CPAP versus oxygen therapy, and everything sort of leans more towards CPAP. So how do you actually diagnose someone with overlap syndrome? What kind of clinical assessment would you do? Patients with COPD generally report poor sleep quality and daytime fatigue. Obstructive sleep apnea patients typically present with excessive snoring, unrefreshed sleep, and excessive daytime sleepiness. So there's a little difference a little bit between the two. Polysomnography is the gold standard to detect overlap syndrome. You need to do a polysomnography on the patient. Overnight oximetry can be used as a simple screening test to detect nocturnal hypoxia during sleep. So the gold standard for overlap syndrome is a polysomnography, but you can use overnight oximetry to detect nocturnal hypoxia. And I'm going to show you a graph on the next slide. So the clinical assessment of overlap syndrome can be determined with oximetry and polysomnography. Basically, if you see a sawtooth pattern on an overnight oximetry, this may indicate apnea in a COPD patient, but again, you need to do the polysomnography test. In COPD, they got what they call the gold stages. They have mild, moderate, severe, and very severe, or stages 1 to 4. They did a study called the Sleep Heart Study, and that suggested that patients with mild COPD who have gold stage 1 and 2 may not reflect classic symptoms of OSA or may not be disturbed in quality of sleep. So if you have COPD and you have stage 1 and 2, which is considered mild, you may not show that you have any kind of OSA symptoms. So this is like some of the clinical assessment tools that are used for overlap syndrome. And now I'm going to be talking about treatment options. So let's talk about treatment options for patients with overlap syndrome. Patients who have obstructive sleep apnea and COPD, you need to reduce their cardiovascular mortality and improve their survivability of these patients. So first of all, you got to identify who they are. Second of all, you need to come up with a treatment plan that can help them. And the basic treatment plan for overlap syndrome is to maintain nocturnal oxygenation and also at the same time improve the AHI of these patients. This will improve their sleep quality and this will improve their outcomes, in regard to cardiovascular mortality. There are certain interventions you can do, and we're going to go over each one. Lifestyle modifications, supplemental oxygen therapy, bronchodilators and corticosteroids, CPAP, and then non-invasive ventilation. Each of them have their role in the treatment of overlap syndrome, and I'm going to get into more detail as we move through each slide. So let's talk about lifestyle modifications to improve overlap syndrome. Obviously, when we're talking about lifestyle modifications, we're talking about benefits to both the COPD patients and the obstructive sleep apnea patient. COPD rehab has been around a long time, and there's so much articles out there showing that it's beneficial to patients for so many different reasons. But they've been doing some recent studies of OSA patients, and they find that there's a lot of benefits to exercising and lifestyle modifications for both COPDers and OSA patients. Some of the behavioral modifications, we got to just throw it right out there, is the cessation of smoking. If anyone's continued to smoke, even if they're OSA or COPD, they really got to stop that. Also, we learned from sleep hygiene that, sleep hygiene is really important. So maybe COPD patients are not really versed on sleep hygiene techniques and should be brought up on those, like things that going to bed at a certain time, don't, no electrical devices when you go to bed, and, so on, don't eat before you go to bed, and a whole list of things that make up sleep hygiene techniques. But they've done some studies, and they've showed there was improvement in skeletal muscle wasting, and that especially occurs with the COPD patients, improvements in daytime sleepiness, improvement in overall sleep quality, a significant reduction in AHI. They did some studies with OSA patients, and they found that exercise and lifestyle modifications really improved AHI values overnight. Not overnight to the point that you'll get maximum benefit overnight, but it does improve over time. And actually, it increases maximum oxygen consumption, which really helps the COPD patients. So lifestyle modification, eating right, exercise, behavioral modifications such as smoking cessation, sleep hygiene techniques, all benefit these patients. You cannot put a dollar value on that. And these are all things that you could do yourself where you don't need much help. So while we were talking about lifestyle modifications in COPD and OSA overlap syndrome, I found a very interesting article about esophageal reflux disease, commonly known as GERD, and COPD. And they really mentioned this with the patients who have overlap syndrome. So there's a relationship between GERD and COPD and overlap syndrome. And I found this article, and it was just published in 2021. And it's called The Role of Comprehensive Lifestyle Interventions in Managing Gastroesophageal Reflux Complicating COPD OSA Overlap Syndrome. Long name, but I'm going to get into the gist of the study. So while we were talking about lifestyle modifications, I thought I found this pretty interesting article about GERD and its relationship with COPD and especially OSA and overlap syndrome. So basically, for those who don't know what GERD is a digestive disorder where the stomach contents actually come up and are aspirated into the lung. A lot of patients who have asthma, who are diagnosed with asthma, actually have GERD, so they give them medications for GERD, and it takes care of the asthma. The medication most likely given is Nexium, which is like a proton pump inhibitor, but that type of medication works very good by keeping the gastric contents down. So they also found at the same time the most common treatments for COPD patients are long-acting beta agonists, anticholinergics, and corticosteroids. And they found that when you take these medications, it lowers the esophageal sphincter pressure. So basically, it can facilitate gastric contents being aspirated. So they found an association between the medications that COPDers take to maintain breathing and getting GERD. So they had some treatment options in this group. They said avoid late night dinners. Technically, you're supposed to have a dinner 3 hours before you go to bed. you're supposed to keep your head of bed elevated, which is most likely what COPDers do anyway. And they say if you happen to sleep on your side, sleep in the left lateral position versus the right lateral position, because it actually reduces the likelihood of aspiration. And finally, exercise, which we mentioned before. Exercise doesn't hurt at all. But I thought it was kind of interesting that they did this with patients with overlap syndrome, and they found a correlation between the treatment options that COPDers have and the likelihood of getting GERD, and kind of interesting. So just thought I'd throw it out there. In COPD patients, those who suffer from nocturnal hypoxemia, oxygen therapy is the cornerstone of their care. This is how you manage patients. Studies demonstrate that if a patient who has this COPD and poor oxygenation, 18 hours a day of oxygen therapy can improve nocturnal hypoxemia and reduce the risk of mortality in these patients. But there is an exception. Patients with overlap syndrome may be subjected to hypercapnia with the use of oxygen therapy. They found that many of the patients who have overlap syndrome also have hypercapnia. Therefore, oxygen therapy or supplemental oxygen therapy is typically not recommended for overlap syndrome. Inappropriate long-term oxygen therapy in these patients with borderline hypoxemia and overlap syndrome may increase mortality, increase hospitalizations, and increase acute exasperation. There's one exception. Supplemental oxygen with a target range of 88 to 92% should be considered with patients with overlap syndrome who continue to have hypoxemia despite PAP therapy. So if you have a patient on PAP therapy who has overlap syndrome and they are desatting at night and they have hypoxemia, nocturnal hypoxemia, you may want to bleed in some supplemental oxygen with them. So let's talk about pharmacological therapy with patients with overlap syndrome. Oxygen therapy is a drug, and oxygen therapy does improve nocturnal oxygen desaturations, or NOD, with COPD patients. Many studies have shown the positive benefits of that. Studies have also shown that patients who take ipratropium bromide 4 times a day actually have improved sleep quality as well as increased REM sleep for those patients who have moderate to severe COPD. PAP therapy in overlap syndrome has been shown to reduce the need of bronchodilators with patients with COPD, which is kind of interesting. Patients who receive positive airway pressure actually benefit by having reduced needs for bronchodilators. And finally, LABAs such as salmeterol or LAMAs such as tiotropium have been shown to increase nocturnal oxygen saturations without improving sleep quality. So, it's kind of interesting that it improves your SATs, but it doesn't really improve the quality of your sleep. So those are a little bit about some pharmacological therapies, and I have a little bit more on corticosteroids. Regarding inhaled corticosteroids, the evidence is kind of contentious. It's like one study says one thing, the other study says the other. For example, one study shown that inhaled corticosteroids will improve AHI, nocturnal hypoxemia, daytime PCO2s, and lung function, and they believe it works via the airway anti-inflammatory effects. Due to the fact that these medications are anti-inflammatory, that's where the benefit lies. However, other studies have shown that inhaled corticosteroids predispose the patient to myopathy, which will worsen upper airway collapsibility, leading to OSA. So again, inhaled corticosteroids, the studies are sort of mixed. One says they're good for you, the other one says they're not good for you. I'm not exactly sure. It's sort of a contentious topic. Regard to sedatives and opioids, they should be avoided with COPD patients because it worsens central hypoventilation. So that is the story with inhaled corticosteroids, and I know inhaled corticosteroids is the mainstay for COPD, but you see this mixed evidence out there. Acetazolamide is a medication that they were considering using with overlap syndrome. And basically, this medication is for patients with glaucoma, and it is also for patients with altitude sickness. And the value of this medication, it is a stimulant. So they really never done much studies of using this medication as a respiratory stimulant, even though they do use it in some certain cases of COPD. And it has been shown to improve the oxygenation status of patients with COPD, but it really doesn't improve their overall outcomes. They say that this medication, acetazolamide, may potentially cause harm. It could cause worsening respiratory acidosis and severe COPD. Therefore, respiratory stimulants in this particular class is not recommended for overlap syndrome. It should be of no surprise that CPAP therapy, or continuous positive airway pressure, is the mainstay therapy for obstructive sleep apnea and overlap syndrome. The way it works, it actually reduces airway resistance, thereby reducing nocturnal hypoventilation. So basically, with a collapsed airway, the CPAP, I'm not going to go into the theory of how CPAP works, but you all know the positive pressure keeps the airway open, and this improves ventilation, and so nocturnal hypoventilation is greatly improved. When you use CPAP, there's a great reduction of reactive oxygen species, mean free radicals. We all know the damage that free radicals cause: inflammation, pro-inflammatory mediators. So when you use CPAP, it's a great reduction of these reactive oxygen species, and there's also improvements in sleep apnea, FEV1s, PaO2s, PaCO2s, and mean arterial pressure. So the benefit of CPAP is enormous. CPAP therapy can improve the survival outcomes of patients who suffer from COPD and obstructive sleep apnea, and it also reduces COPD exacerbations. So it's a plus-plus win-win situation. I'm sure you all know about CPAP, but in this particular case, with overlap syndrome, it is the mainstay therapy. This is a very interesting study. It was a study done in France where they looked at over 6,000 patients who have obstructive sleep apnea as well as COPD. So what they were looking at, they wanted to look at the symptomatic responses of using CPAP with this population. And this was a really pretty well-planned study. And like I said, it's in France, and they did this over 6,000 patients. And they were looking at, the benefit of CPAP in this population. So as I was mentioning, this study consisted of 6,000 patients with OSA as well as overlap syndrome, and they wanted to understand whether CPAP was good for obstructive sleep apnea, or was CPAP good for patients with overlap syndrome. They wanted to see the benefit. They know it works very well with OSA patients, but does it work well with overlap syndrome? And so the aim of this study was to explore the main difference in the clinical response to CPAP treatments in overlap syndrome compared to OSA alone. And they measured CPAP efficacy with the residual apnea-hypopnea index, and also they measured it with adherence. Like I mentioned earlier, a lot of patients are not adherent to using CPAP, and that is part of the problem. CPAP therapy was effective in normalizing the normal AHI and significantly improve OSA-related symptoms regardless of COPD status. So there was very positive outcome. So the suggestion based upon this study that CPAP should be offered to patients with overlap syndrome on a trial basis as a significant improvement in OSA-related symptoms can be expected, although the range of response may be less dramatic than in OSA alone. So what they're saying is the overlap syndrome patients are more of a challenge because, yes, they have COPD too, but it should definitely be offered and you should do this. So the point here is, yes, overlap syndrome can respond quite favorably to CPAP therapy. So what about the use of non-invasive ventilation with overlap syndrome? This is fairly a new area in overlap syndrome treatment modalities. Non-invasive ventilation is typically quite effective for COPD patients who suffer from hypercapnic respiratory failure. So patients who are COPDers who retain a lot of CO2, non-invasive ventilation at night has been shown to improve both nocturnal hypoxemia, quality of sleep, and actually also shown to improve CO2 levels at night. Long-term use of non-invasive ventilation in COPD patients improves lung compliance, prevents atelectasis, and actually reduces the work of breathing. But like I said, there's limited research and literature on the benefits of overlap syndrome and the use of non-invasive ventilation. But there are some studies which I'm going to show you a couple of the benefits of using NIV, especially for those COPD patients who are retainers, people who retain a lot of CO2 and hypoventilate at night, resulting in increased CO2 levels. So let me go on and show you some more literature. So I found another study on the use of non-invasive ventilation for patients who have COPD-OSA overlap syndrome. And they wanted to know, was polysomnography useful in this group of patients? And what they found is they did a small study of 12 patients, all of them identified as having obstructive sleep apnea and COPD. And those patients benefited significantly by having a polysomnography test done with the utilization of non-invasive ventilation. So the bottom line story here is that if you happen to be on non-invasive ventilation for overlap syndrome, polysomnography is really important to do with these particular population. In this study, the European Respiratory Journal did a study looking at the safety and efficacy of auto-titrating non-invasive ventilation in COPD and obstructive sleep apnea overlap syndrome. So this was a study done from 2015 where they were looking at auto-titrating controls in non-invasive ventilation. And the reason for that is they felt that if they could control the amount of flow and settings going on with non-invasive ventilation, it would be better adherence and compliance with using it, and the patient would be more comfortable. As I mentioned earlier, sometimes CPAP is not enough for a patient who's a COPD and they retain. So certain populations of COPD patients who have overlap syndrome really need to manage CO2 removal, and that is the reason why they use non-invasive ventilation rather than straight CPAP. CPAP will open up the airway, but it will not remove CO2 as well as non-invasive ventilation. But they found that many patients really didn't like non-invasive ventilation because the flow was too high and they were uncomfortable. So they used these auto-titrating techniques with non-invasive ventilation where EPAP levels can be manipulated and IPAP levels could be manipulated and progressively go higher and higher. And they found that these patients benefited greatly with the use of non-invasive titrating methods. So I just want to let you know, again, there's a certain segment of population of overlap syndrome who are COPDers, who retain, who need non-invasive ventilation versus CPAP because they retain at night, and these type of modes of ventilation work much better, especially when you have these auto-titrating devices work with them. As I was mentioning through this presentation, they are doing some new studies, and they're looking at studies on non-invasive ventilation regarding overlap syndrome. As I mentioned, there's a segment of population who are COPDers. They also have OSA, but their problem is that they retain CO2 at night. So those patients most benefit from using non-invasive ventilation. So they're doing some new studies on that particular group versus CPAP. Then they actually have another studies where they're looking to see if CPAP works better than non-invasive ventilation in groups that are not like these COPD patients who retain. In other words, is there better compliance? Is there better outcomes with just using non-invasive ventilation? So they're doing some new studies in both categories. There are a couple of other modes of ventilation that have been working very well for COPD patients as well as overlap syndrome. One of them is called volume assured pressure support. They also have another mode called average volume assured pressure support. Basically, this is used with non-invasive ventilation where you can have a fixed and or auto EPAP setting that basically has an automatic titration of IPAP levels to improve chronic hypoventilation in patients who go to sleep at night. So how it works is this. You have a an automatically titrating IPAP level. So based upon the ventilatory drive and the patient's effort and also the different postures in sleep, if it takes more pressure to open the airway, it will do this automatically. It's been very helpful in maintaining minute ventilation to remove CO2. So patients who use VAPS therapy or AVAPS therapy have been shown to have more stable minute ventilation, more clear CO2 removal. Another one, another mode of ventilation is kind of similar. It has an automatic tri-level PAP therapy. So basically, it starts you off at a lower level, and then as your airways collapse, it increases the level to give you better ventilation. This study has shown to be superior to BiPAP. It improves the AHI, it improves nocturnal hypoxemia, and improves sleep efficiency and daytime sleepiness. So these automatically titrating modes on non-invasive ventilation have been proven to be quite successful, and VAP therapy or this other one about this tri-level PAP therapy have been shown to be very good. In summary, overlap syndrome has been a significant impact on many patients who suffer from COPD and obstructive sleep apnea. We never really sort of figured out until recently that patients with COPD do have sleep abnormalities. And we're also talking about research that could manage these patients. Most of these patients can benefit from some form of therapy that I mentioned earlier. Now that we recognize exactly what this syndrome is, we could sort of do something about it. And, you know, new research is coming out all the time on this, like I was telling you about the automatic titrating PAP levels and all these other bells and whistles that go along with mechanical ventilation, most likely with non-invasive ventilation to do this. I want to thank you for joining my presentation. I have many more references than you see here, but I thought that this would be a good starting point for you to get a good handle on it. And I want to thank you so much for joining me, and you have a great day.